at NICE who developed this guidance. John is also the Professor of Epidemiology at the and Respiratory Medicine in Nottingham and Director of the UK Centre for Tobacco and Alcohol Studies. He's also Chair of the Tobacco Advisory Group at the Royal College of Physicians. So John is going to kick us off, and I'll hand over to John in just a moment. We'll then hear a pragmatic presentation from Leslie in the North East about their experience of implementing smoke-free policy, and then we'll move on to hear about Debbie's research on evaluating smoke-free policies, and finally we'll hear from Matt at the CQC, who's going to talk about their guidance to inspectors. So without further ado, I will hand over to Professor John Britton to give us an overview of the NICE guidance on smoking in acute maternity and mental health settings and what full implementation means. So over to you, John.
Right, can everybody see a first slide? Can somebody tell me whether that's showing? Okay, well, I'll assume it is. So, yeah, my name's John Britton. I chaired the group that produced the NICE guidance, and the guidance was published in November 2013. And just by way of explanation as to who was involved in that, I don't want to go through all the names, but the group was big. It involved people from across health services and provision of secondary care. Those people listed down on the left on this slide, so it's quite a broad spectrum. And then some excellent support from the NICE project team who led the analyses and systematic reviews behind the guidance. The guidance was based on a series of commissioned reviews and expert papers. The commissioned reviews on the left there went across the spectrum of topics relevant to smoking in secondary care. And they were extremely extensive, and they took evidence published up until about 2012 when the panel first began to meet. But we recognised as a panel that there were some gaps in the evidence, either things that weren't covered by peer-reviewed papers or work that was in progress that we thought should be included in the guidance. And we took that evidence through a series of expert presentations listed there on the right. Now, all of this evidence is still available on the NICE website. If anyone wants to access the full detail, it's clearly impossible this morning to go through it all. So what I thought I'd do is just summarise the key messages that came out of this whole process, rather than just go step by step through the guide. And the key messages were these. First of all, that stopping smoking at any time in anybody's life has considerable health benefits, so it's always worth encouraging people to quit. Secondly, that secondary care providers actually have a duty of care to protect the health of and to promote healthy behaviour among the people who use or work in their services. Providers must also provide strong leadership and management to bring about the kinds of changes that are necessary to start dealing with smoking like the significant health problem it is, and that is to prepare patients, visitors and others who use smoke-free services for the fact that when they come in to use them, they will have to be smoke-free. To identify patients who use the services and who are smokers and make sure they are given good support to stop or at least to remain abstinent from smoking while they're on site. To develop smoke-free policies that support this approach and commission services within the secondary care setting that support them. To help all staff to stop smoking because staff are such an important role model. And to train frontline staff to deliver stop smoking support to the people who use our services. And we also recognised on discussion that exemptions and special cases to an overall policy of being smoke-free and of encouraging people to quit were undefinable and unworkable. And this was particularly important in relation to these two boxes on the next slide, which were the original scope for this guidance development group. And the assumption was, when the first call went out, that we would use separate guidance for acute and obstetric services to that provided for mental health services, because even then, within NICE, it seems that there was a perception that mental health services are different and that standards would somehow be different there. And what we realized quickly as a group, that this was completely unworkable, that it was not possible or right or remotely justifiable ethically to treat people using one part of the NHS to a lower standard than people using another. And so we argued that the guidance should be united into a single document, and NICE, to their great credit, agreed and supported that approach. The principles of what need to happen now across the secondary care estate are here. Planned or anticipated use of secondary care is the opportunity to make it clear to users and visitors that our services are smoke-free. Most use of secondary care is planned or anticipated, and even the most emergency admissions are often in people who've been admitted before and who can expect to be admitted again because of recurrence of chronic disease. On admission, we should ascertain smoking and advise abstinence at the first face-to-face contact. We should make sure that people have immediate access to the smoking cessation therapies, particularly NRT, that help to deal with cravings to smoke. We need plans in place straight away to deal with the fact that some medicines, particularly some of the more extensive antipsychotic medicines, need to be used in lower doses in smokers. So there's a big improvement in dosage and cost saving to be had there. Patients, carers, friends, visitors all need to know that the site is smoke-free through the correspondence that goes out from hospitals, through local media and so on, and need to be able to access NRT. And they need to be sure that there is continuity of care after people leave secondary care services, so that community support is available. We recognised, and we'll be coming back to this later in the seminar, that strong leadership and management are essential for this to work. Smoking services have to be available on site. It's no use referring smokers to some remote community-based support. It has to be delivered there and then at the bedside. Staff have to be trained to support people in this process, and staff themselves should be encouraged to quit, and if they can't quit, at least not to smoke while identifiable as NHS staff. So not smoking in uniform, not smoking while wearing an NHS ID badge. And grounds have to be smoke-free, otherwise we have the issue of patients, as in my case, looking out of my inpatient ward window and seeing people standing outside the window smoking, while inside is a patient struggling with cravings to smoke while trying to quit. So no designated smoking areas, and certainly no staff facilitated smoking breaks for patients. Cessation support must be intensive. The evidence in hospital use was that low-level intensity interventions don't work. It has to be pharmacotherapy with at least 4 weeks behavioural support. It should be started within 24 hours of admission, and it should be delivered on an opt-out, not an opt-in basis. Somebody needs to come to the bedside and say, I'm here to help you with your smoking, not would you like to consider stopping. The barriers to intervention in acute services that we identified were mostly to do with staff awareness and education and training. Healthcare staff smoking is a big obstacle to intervening. Healthcare staff who smoke are much less likely to address smoking among their patients. Perceptions of a lack of time or knowledge or skills or training, all of which can, of course, be dealt with by appropriate training programs. Then our systems need to include prompts and reminders, and to make sure that smoking is ascertained and acted upon. And our hospitals have to deliver the behavioural support and make sure that stop smoking medicines are available on site. Still, too many hospitals don't do that. Make NRT or other anti-smoking medications, things that people have to go off-site and get from their GP. And there were some misconceptions that stopping smoking before surgery increases the risk of complications, which our reviews demonstrated grounded in fact. In mental health, these same considerations applied, but there were other obstacles. One is that the effectiveness of smoking interventions is less in people with mental health problems, largely because they tend to have much higher levels of addiction. And therefore they need to be very intensive to have a chance of working. Bupropion came out of the systematic reviews as being particularly effective in this patient group. At the time of the reviews, there was very little evidence on varenicline, but I believe that that has now changed. But the barriers, which were also the same, but included this whole issue of the historic culture of smoking in mental health settings, staff facilitation of smoking, using smoking as a means of control or relationship building, a belief that cessation would exacerbate mental health problems when in fact the converse is almost certainly the case, a belief that smoke-free services would discourage patients from using them, concerns that smoke-free policies would lead to fires and abuse and aggression, and then good old medical paternalism, making decisions for our patients to say that we shouldn't intervene, it's their only pleasure. Commissioners have a huge role to play in achieving smoke-free settings, and so I just show this slide to remind me to say this really, but it's to draw out the fact that if our commissioners demand that the services that they commission are smoke-free, so many of the incentives or drivers for our managers who have other priorities to concentrate on smoking can be changed. That balance can change if commissioners insist on smoke-free policy. The economic case in favour is huge. In the short term, 3-year time period, in common conditions where evidence is available, stop smoking services are cost effective to the most part, apart from perhaps in pregnancy where the evidence was very poor. But across the board otherwise is cost effective and in many cases cost saving, which is what dominant means. Over the longer term, these are not only life saving, but heavily money saving interventions. It can be done, and we'll hear more of that. Cheshire and Wirral Partnership was the first trust I heard of to go smoke-free after the NICE guidance was developed. It was led by Avril Devaney. It was presented as a nicotine management policy, not a question of making people quit smoking against their will, just a question of not smoking while using the service, making sure that services were provided to those smokers, and in the case of this particular trust, ensuring that smokers were seen by a trained behavioural counsellor who was able to dispense NRT within 15 minutes of arrival on site. And hospitals such as this one from the northeast, who just draw attention to how we can take the finger wagging, you shall not smoke while on our premises approach, or we can take a more positive and fresher, cleaner and healthier approach to the way that we promote this policy. But that, in the time I have, is all I wanted to say. I think I'm within time. That's the background to the guidance, and I look forward to hearing more detail from others who had to deal with implementation in the following presentations. Thank you for your attention.
Thank you, John. That was a really good overview of the public health guidance, and I'm sure that people will have questions. So don't forget that you can pose your questions in that question panel on the side. You can add your questions there and we will put them to John at the end. So having heard the kind of overview of the guidance, we're now going to hear from Leslie about the practical experience of implementing this guidance. So Leslie is the project leader for nicotine management and smoking cessation at Tees, Esk and Wear Valley's NHS Foundation Trust in the North East, and she supported the trust to go fully smoke-free in March 2016. Leslie has 15 years experience of working with stop smoking services and transferred from an acute hospital trust in 2015 to support the mental health trust to go smoke-free. So Leslie is now going to share with us the experience of the trust and the challenges that they are continuing to face through implementation. So would you, we can't see your slides yet, Leslie, so you need to bring them up, I think. Oh, there we go. Just bear with us. Technical challenges of using online facilities. And Leslie will just dig out her slides and we'll be able to. There you go, webinar. Right. Leslie, we shall hand over to you.
Thank you. One of the key elements to the success, we think, of going smoke-free is to fully read and understand the guidance that John's just referred to, so the PH48. Somebody really needs to sit down and actually go through the guidance to have a full understanding of what the implications are for successful implementation of it. As a project lead with the support of an operational steering group, we looked very carefully through the guidance and then looked at the 16 clear recommendations to implement guidance. And this was very much the very first thing we did, was to find the recommendations. They very easily fit into 6 subgroups, as you can see on the chart. So we then worked very much looking at these 6 subgroups as well as our operational group to work through. Key people were identified for each group. So very much we included hospital pharmacists, local authority commissioners, estate staff, modern matrons and ward managers from the wards, to name just a few of the ones that we actually engaged with. And then we really wanted to engage with our service users and carers in the trust. So we sent out invites to see if any of our patients or our carers would like to support us, and they did. So throughout the whole of our 9 to 12 months preparation and time to go smoke-free, they were involved with some of the groups. Specifically, they like to join the provision of information and training and how to identify a smoker and offer support. They felt that they led very well within those areas to give us advice and support. The service users and carers also supported the development of information leaflets and very much influenced the way that we would support smokers in our care. So it was because of their voice that we realised how quickly people needed access to nicotine products as quickly as they actually got to the ward. So we very much drafted that into our work. This work from the service users and carers, and especially on the wards that we spoke to, led to the offer of free e-cigarettes on admission. So we actually, in our trust, Tees-Esk and Wear Valley, we give free disposable e-cigarettes to any patient who would request one on admission. And we've actually given out well over 1,000 free e-cigarettes to somebody coming into our care. And we also offer the choice of free nicotine replacement products via our homely remedies pathway. So work actually on the guidance went really well to begin with in setting up the operational group and then setting up the 6 subgroups. So we then moved on to key elements to support initial preparations. As John mentioned in his slides, one of the crucial things to the success of the project was to identify a senior lead to support and sponsor the project. In Tees-Esk and Wear Valley, we were really, really lucky to have Nick Land, one of our really experienced medical directors, who had an absolute passion and drive, which is a definite reason we were able to implement the guidance. Although it be a very difficult project to implement, it was really supported by Nick. Following successful interview, I was appointed from an acute trust to come and work as a project lead to support Nick. And I now work with Tees-Esk and Wear Valley in the Mental Health Trust. We luckily also had a clinical director, Angus Bell, who also was as passionate as Nick in taking us forward and leading. So the 3 of us actually supported the operational group and the steering group, and we moved forward with the work. What we decided to do was provide a monthly operational group, and the group's priorities were to review all of the literature and guidance that we had in the trust already, so any current smoke-free policies, any pharmacy guidance, any guidance on nicotine products, any other literature we could find. So that was actually pulled and we started to review that. We next looked at training requirements because we realised, as John mentioned, that the most crucial element to this was training. And in the 6,500 staff in our trust, I think there was very few had ever had anything to do with training in smoking cessation or nicotine management. So we knew we had a big battle to actually identify the number of staff and see how many we could train before we actually went live. Initially, for our training, we linked with the community stop smoking services, but due to the massive demand for training, we realised that very quickly we would need to develop a training package in-house. Fortunately, as I'd worked with smoking services for 15 years previously, I was a specialist advisor and trainer in my own right. So we developed our own training packages in-house, which I delivered for the first year. We trained as many frontline staff as we could. Occupational therapy staff were key. A lot of the medical staff were trained, hundreds of them through specialty doctors, through forums, consultant forums. So we very much engaged with that. And then we also wanted to, like I say, identify the patients and carers who would support the implementation as well. So we've got our board set up. The key elements to support the preparations, we have everybody in place, from the pharmacist to estate to health and safety. So everybody was now in place, along with the patients and carers to support. So I came into post with the trust the end of March 2015. So it was a bit of a baptism of fire, and we very quickly set up the groups in May. So within about 4 to 6 weeks, we'd identified everybody. We'd set up the 6 subgroups to support the operational group, and work commenced to develop identified information to support going smoke-free. We identified all information to support and started to review, and patients, carers and staff were all identified. The next thing we did was we actually held a conference, and within this conference, Cheshire and Wirral came to speak, other trusts who'd gone smoke-free came to speak with the attendees. There was about 100 attendees, and it was a brilliant conference which gave staff the opportunity to discuss and learn from trusts who've already gone smoke-free, and look at those trusts who needed support, as we did, to actually help us to go smoke-free. Very, very valuable. And the information gained from other trusts who'd already gone was absolutely phenomenal. The second conference we held was for service users and carers, which was in November of 2015. And this allows the opportunity to openly discuss any concerns or fears, whilst also providing an opportunity to discuss the positive outcomes. We had patients came from our forensic services with the staff who looked after them. We had patients from the community, we had carers. It was quite a heated discussion, but absolutely we embraced this because we could learn very much from what the patients had to say to us and what the carers said. On a positive note, there was a number of parents of children in our care who said that they wanted to protect their children from secondhand smoke, and they were fully supportive of the trust going smoke-free. So we definitely had engagement from both areas. So that conference was really well attended and really gave us a lot of information. The very next step we needed to decide was a go live date. Until you've got a go live date, you can't actually move anywhere. So in the May, we decided the 9th of March, National No Smoking Day in 2016, would be our target date to go smoke-free. And we worked very closely with Northumberland Tyne and Weir Trust, who went, the Mental Health Trust went at the same time as us. So we had then about 8-9 months to actively get everything in place to go smoke-free. So we very quickly got all the guidances, updated the nicotine management policy. We followed Cheshire and Wirral's guidance. Instead of a smoking cessation policy, we very much carry out nicotine management, so either temporary abstinence or smoking cessation should they wish. We developed a brand new pharmacy guidance which had all the nicotine products available to our trust, and we incorporated a homely remedy information. We've got a full guidance. The homely remedy allows any qualified nurse in our trust to access either a 16-hour patch and or a nicotine inhalator within minutes of admission and hand to the patient without the need of a prescription. So any nurse can access these products immediately on admission and hand them straight out. So we realised that this was really beneficial and has proved so, with thousands of nicotine patches and thousands of inhalators being handed out within the first year of going live. So the homely remedy was definitely the best pathway for us. We also had a detailed project plan, which had to be, and it was very complex, and we ticked it off every Friday. We would sit and go through every Friday and work out what we'd achieved. We also had a detailed communications plan. Communications team were absolutely crucial to success and heavily supported us. And they also supported the development of the information leaflets along with the service users and carers, which is still available to our patients now. And then the training materials and programme delivery, we developed a whole programme for that work. Discussing training, we then moved on to what we would actually do for our training. We very much from the NICE Guidance were guided by the NCSVT, the National Centre for Smoking Cessation and Training. We quickly started work on allowing our staff to access the level 1 very brief advice online. We then used the level 2, and at 2 to 3 staff per ward were asked to complete the level 2 NCSVT training, which they did. So initially we had 1,500 staff trained to level 1, 189 staff trained to level 2. This year, from March 16 to March 17, we very quickly realised that the level 2 can be quite intensive for some staff to be able to complete whilst they're busy on the wards. So we've developed a 2-hour brand new brief intervention training, which we actually go to wards and to community teams and deliver in-house, and that has gone down really well. The latest figures we've got just under 2,000 staff now trained in either level 1 brief intervention or level 2, and we actively train at least 3 days a week. We're out training our staff throughout the trust, giving regular updates. So training-wise, if you do anything, start your training immediately and get as many staff trained as you possibly can. It definitely changes staff perceptions as we move forward. So where are we now? Fortunately for us, we carried out a baseline audit in December 2015 before we went live in the March. And then we compared that to a recent audit, which was completed January, February of this year. As you can see, initially, of our 660 plus beds, 42.5% of patients across all of our services, from young people services, old people services, everywhere, forensic services, 42.5% were recorded as smokers. At Christmas, it had gone to 28%. So we've actually got nearly a 15% reduction in smoking rate since we actually went smoke-free. All specialities have seen a reduction in smoking rates, which is phenomenal. We didn't think adult services, which is our biggest challenge, would see a reduction. We had a reduction by 6% in smoking rates. 98% of all patients admitted to our care were offered a brief intervention on admission. They were asked if they smoke, they were advised of the support, and they were given help to stop smoking. We were over the moon that 98% of patients were offered brief intervention. Of those who accepted a referral to a level 2 trained staff, 95% of those had a complete assessment on our Paris system available to us. 95% of all patients were offered homely remedies, so were given patching in the later on admission. And 80% of those patients who got homely remedies were offered them within 30 to 60 minutes of admission, which we think is a really good thing, that our patients are being offered as quickly as we possibly can. That's inclusive of the disposable free e-cigarettes as well. And probably the best thing that we came out of our audit was 10% of our identified smokers actually said they were going to be smoke-free when they went home. So 22 of our patients actively chose to take products home or remain on the e-cigarette and stay quit long-term. Hopefully we're going to carry out this audit every Christmas, and hopefully we're going to see increases in the number of people who actually decide to remain smoke-free on discharge. Last few slides, evaluation. We're very fortunate that Public Health England and FUSE, who are the North Sea Centre for Translational Research, are supporting us to carry out a full evaluation of the work we've done. And the final evaluation report should be available late 2017. We're hoping for November. We'll be very interested to see that. And then just a couple of slides really on our lessons learned. A lot of the words that John said at the very beginning are exactly what we found. Staff were our biggest resistance to change, our biggest barrier. I must have spent hours and hours and hours in the first year in meetings being told that it was human rights and that we shouldn't be doing this, no matter that patients will die up to 20 years earlier than they should. Patients, we found, continued to smoke in grounds when we first went smoke-free. We made sure we removed all smoking shelters. We didn't have a lot, but we made sure those went. When we stopped them smoking in communal areas, in like courtyards and garden areas, patients took to smoking in their bedrooms or went to the courtyards at the front of entrances. Over a period of months, they then moved outside of the hospital into bush shelters outside of the trust, and we worked on that piece. Staff facilitated smoking, and sometimes still do, especially after 7 o'clock at night when staff have gone home. So we very much are aware of that. And as I mentioned, human rights is often raised. Section 17 leave. Initially, a lot of consultants gave Section 17 leave to patients. Every patient on the ward was given it to facilitate smoking. We see a far less of that now because our consultant was very good in that, and he actually spoke to consultants, and we've done a lot of work and spoken to a lot of staff. So we very much have seen a massive reduction in Section 17 leave given to smoking. We found staff left often or moved departments, so we constantly have to keep giving training and updating our training on wards because staff move on. We've initially found a lot of staff smoking in cars, so we're tackling that through our unions and through our executive boards now, so that staff are aware now that that won't be accepted. We're working with staff to stop them smoking in cars. We on occasion have contractors who were caught using the tank model e-cigarettes and setting off fire alarms in patient areas, so they were removed from site. So we have had issues where contractors haven't been aware or haven't listened to and adhered to the policy. On the back of what we've discussed, I would definitely say ensure enough preparation time is available, at least 12 to 18 months to go live. We didn't have that luxury. We had 12 months and then only 9 months when we decided the date. And make sure additional funding has been identified for NRT costs. Before we went live, we used to spend about £20,000 as a trust. When we went live in the first year, we spent 80,000. But we're now down to about 35,000 in our trust for the time being. And thank you.
Thank you, Leslie. That was a really interesting look at the practical experience of going smoke-free, and really quite inspiring when you think about the results that you're starting to achieve. I think I really take from that it's you know, the process of bringing the patients, the carers, and the staff along with you are every bit as important as the policy. But we started to have a look there at the evaluation of the experience in Tees, Esk and Weir, and now Dr. Debbie Robson is going to talk to us in more detail about the evaluation of smoke-free policies, evaluating the impact of smoke-free policies. Debbie is a mental health nurse and a postdoc on tobacco addiction research with the National Addiction Centre and the Institute of Psychiatry, Psychology and Neuroscience at King's College London. Her current role involves the development, implementation and evaluation of tobacco dependence treatment initiatives for people who smoke at the South London and Maudsley NHS Trust. And Debbie's going to talk about some research which she's been doing, so I will hand over to you now, Debbie.
Good morning, everybody. It's really great to be part of this webinar, and thanks to Ash for inviting me. Following on from Leslie's brilliant presentation, I'm going to talk about some of the evaluation work that we've been doing in South London. And I'm particularly going to focus on staff concerns rather than patient outcomes. And I'll focus on concerns around not having enough time to implement smoke-free policies and staff fears about fires and in particular violence. So to give you some context, I work for King's College London, which is the university arm, King's Health Partners, academic science centre in South London, and we work with 3 partner NHS trusts, all of whom have implemented comprehensive smoke-free policies. And the South London and Maudsley NHS Trust, or SLAM, is our mental health provider. So it's got 4 hospitals across South London with about 49 wards, and sometimes there's more and sometimes there's less depending on clinical need. We've got about 200 community services. And SLAM introduced their comprehensive smoke-free policy in October 2014. And it took several years of work to get to that stage. And in the 12 months leading up to the Trust Board announcing that the whole of the trust could go smoke-free, we started working on developing treatment pathways in collaboration with our pharmacy services, and also developed extensive training pathways and an e-cigarette policy, and improved the infrastructure of the organisation. So we created new posts, we created a hospital stop smoking service, we made some changes to the electronic healthcare record, so we made the recording the smoking status mandatory, and we introduced an electronic referral system. And we also ran a lot of staff engagement events. And during these events, and also when I was delivering the training, staff weren't that concerned about the treatment of tobacco dependence. They were mostly concerned about these issues. So they were saying things like, we don't have time to help people stop smoking. Or if we stop people from smoking, they're just going to be smoking in their rooms and there's going to be fires. No one will want to come into our hospitals, so we'll just have wards full of detained patients. And the most frequently cited worry was, well, we're going to get punched. There's going to be an increase in violence. So it became quite apparent that whilst we were developing these new initiatives, so the treatment pathways and training pathways and improving the infrastructure, we also had to address staff concerns about implementing the policy. So one of the first pieces of work we looked at was this, the perceived lack of time. And what we did 6 months prior to the implementation of the policy, we surveyed staff from half of our wards across the 4 hospitals. And 18 out of 25 wards had designated daily supervised smoking breaks. The remainder of the wards, it was just a bit of a free-for-all, and people could go out into ward gardens and smoke 24 hours a day if they wanted to. So the average number of breaks per ward was around 7.6. So they ranged from 2 breaks a day on a ward that had been trying to implement a smoke-free policy ahead of the trust-wide rollout, up to 18 smoking breaks a day. So the average amount of time dedicated to supervising smoking by clinical staff was about 2.5 hours a day. And when we worked out the opportunity cost, so it's either the least qualified member of staff, so band 2 support workers, or the least qualified mental health staff, so a band 5 worker, once you calculate their time facilitating smoking, it worked out up to just over £86,000 per ward a year. And as I said before, we had 49 wards at the time of the survey. So this study actually helped to then go back to the trust board and to clinicians and managers and reinforce the fact that every time staff facilitate smoking, clinical time's diverted away from therapeutic activities that contribute to improved health. And those therapeutic activities could actually be helping people stop smoking or getting really good at administering nicotine replacement therapy. So when the trust eventually went completely smoke-free, staff were still really worried about the potential for fires. But as you can see here, that the proportion of fires related to smoking was reduced over the 12-month period after the policy was introduced compared to the 12 months beforehand. And then similarly, in terms of the concern that wards would just be full of detained patients, nationally we're seeing a decrease in the number of informal patients and an increase in the number of detained patients on our wards up and down the country. But what we found was that the average number of people detained each month was similar to the 30 months before the smoke-free policy and the 12 months after. So the issue that we've looked at in a lot of detail is staff concerns about violence. So when we were doing the staff engagement exercises, and when I was delivering the level 2 training that I run, staff were telling me about some threats that they encountered. So one ward manager, when she was talking in a community meeting to a group of patients on an intensive care unit, he'd said that, you know, if you try and stop me from smoking, I'm going to carve your face up. And then on another acute ward, there was a patient that said, well, I am prepared to burn this place down if you think you're going to stop me from smoking. So it's not surprising at all that there's some resistance from staff. So what we did, we looked at, we collaborated with colleagues from other universities to look at this in some detail. So Duncan Stewart, he's an expert in inpatient violence, and Lisa Szyakowski, who's a colleague of John Britton's at the University of Nottingham. Lisa's an expert in time series analysis and smoking. And so we got together to look at the effect of implementing the smoke-free policy in Slough. And we did this on 38 wards. We excluded our forensic services because they'd been smoke-free for much longer, and we excluded our CAMS services. And we particularly looked at physical assaults perpetrated by patients towards staff and other patients. We didn't look at verbal assaults because verbal assaults aren't recorded very consistently, and they tend to be, if at all, they tend to be reported. So we extracted the information from Datex, so a lot of mental health colleagues on the call will probably use Datex, which is an online patient safety reporting system. And before we extracted the data, we defined what we actually meant by physical assaults, and we used NHS Protect's definition. So every few months, every mental health trust and every acute trust has to report to NHS Protect in terms of the number of staff who've been assaulted. So we were confident that these would be fairly accurate. So we extracted information where there was a physical assault made directly or indirectly to staff or patients, when there was no visible injury, but also if assault occurred during a patient being restrained. And we also looked at assaults related to smoking. So in the Datex report, you have to say what led up to the assault and how you managed it. So we searched for smoking related terms in the antecedents to the results, to the assault. So just to give you an example of what we mean by a smoking related assault, this was an entry in 2012, so a couple of years before the smoke-free policy. And you can see from that extract, it's a particularly unpleasant experience to have. It was a common experience, unfortunately. So what we did was we used an interrupted time series design. So we looked at the number of assaults every month for 30 months before we implemented the smoke-free policy, and then for each month of the 12 months after the smoke-free policy. And Lisa Szyakowski at Nottingham, she was able to run an analysis that took into account not just that underlying time trend over 42 months, she also factored into the bed occupancy. So who were the patients on these wards during the 42 months? And what were the potential confounders of violence on inpatient wards? So we took into account the proportion of men who were on the wards during this time and how old they were and what their diagnosis was and what their legal status was. And we also accounted for their smoking status. So in terms of the amount of people that were on the wards over 42 months, it worked out about nearly 750,000 bed days, and so we had 18,000 people in those beds over that 42-month period. Nearly half of them were legally detained, and 79% of them were smokers. There was 4,550 assaults during this period of time, but the proportion of assaults related to smoking was quite minimal, so just less than 5%. And this is our time series graph, and I can't actually see the numbers on the end because the webinar thing's in the way. But essentially, we had much more. We had higher number of assaults from patients towards staff than patients towards patients. And you can see that there's an awful lot of variability in the data per month. But once you factor in the time and that seasonality and all those significant confounders of violence on mental health units, you see quite a remarkable reduction in overall violence. So the overall violence is the combination of patient towards staff and patient towards patient violence, which works out about a 39% reduction in violence in the 12 months after the implementation of the policy relative to the 30 months before. And there was a much bigger reduction in assaults from patients towards staff than there was patient towards patients. And we published this study a couple of weeks ago in the Lancet Psychiatry. And it's received an awful lot of attention, despite the fact that there's been several previous studies of the evaluation of the impact of smoke-free policies on violence, dating as far back as the early 90s, which also have demonstrated that violence either remains the same or it reduces. I did an interview with the BMJ a week or two ago, and I said lots of things, but they decided just to tweet one thing that I said, which is about it's time to draw a line under clinicians' beliefs that smoking is somehow therapeutic for mental health patients. And lots of clinicians retweeted that, but lots of clinicians also retweeted this quote as well, that it's time to draw a line under the belief that captivity is an opportunity for staff to impose their lifestyle choices. So we still have some way to go in changing the hearts and minds of clinicians. So broadening this back out to the experience of staff on the ward, and probably Leslie finds this as well. Our early experiences of being on the wards and talking to staff and patients, and still to this day, is that staff say, well, it's just implementing a smoke-free policy has been far easier than we ever imagined. And that patients are much calmer, and why on earth didn't we do this years ago? But I guess you can't really appreciate that until you've lived through it. So all those concerns, particularly about violence and that there was going to be riots and the sky was going to fall down, didn't happen. Patients found creative ways of expressing their dissatisfaction. And just to kind of conclude, and Hazel said this at the beginning, the Independent Mental Health Task Force for the NHS in England recommended that mental health trusts should be completely smoke-free by 2018. And from our experiences, from our local experience, we would argue and reassure staff that a well-resourced smoke-free policy, so that includes treatment and it includes staff training, it has the potential to release clinical time that staff can invest in therapeutic activities that are going to improve health, such as tobacco dependence treatment. And it doesn't appear to have an impact on the issues that the staff are concerned about. And it certainly doesn't lead to an increase in violence and can support other violence reduction strategies in inpatient mental health settings. And that concludes my presentation. Thank you very much. And thanks to our collaborators on the violence paper.
Thanks, Debbie. That was really, really interesting. I think, we heard from Leslie that there are many myths and misconceptions out there among staff, and it's incredibly helpful to have, the detailed, thorough evaluations to be able to counter some of that. So I'm sure, again, we've got lots of questions coming through, so we will look forward to having that discussion at the end. I will now be handing over to Matt Kinton from the Care Quality Commission. Matt is the National Mental Health Policy Advisor. Matt will be talking to us about the CQC guidance on going smoke-free. Matt has been with the National as the National Mental Health Act Policy Advisor for the lifetime of the CQC since 2009, and prior to that had a role for its for the predecessor organisation with the Mental Health Act Commission. His particular focus is the welfare and rights of people who are detained in hospital for psychiatric treatment, and he's been working on these issues going back to the early 90s. So I will now hand over to Matt. Matt, for technical reasons, is going to be not able to move his own slides forward, so we will do that in the office for him here. So over to you, Matt.
Okay, thank you very much. Are my slides up?
They are. We can all see them. Unfortunately, you can't see your slides either, can you? Yes, your slides, we can now all see them.
Right. Okay, well, I mean, the background to this is that CQC provides brief guides to its own inspection teams on issues that otherwise we trip up on or that involve a certain amount of detail that we want people to have access to. And last year we produced this brief guide on smoke-free services in mental health. The reason, the initial reason, and the reason this first slide quotes from the Code of Practice, is that there was quite a lot of discussion within CQC as to whether or not a smoke-free policy was a blanket restriction. Now, to some degree, of course, it obviously is. It fits the basic definition, which is that it's a rule that applies to everybody on site. And I think if we look at the next slide, which I've helpfully numbered 3, which goes on to talk about the way in which the code looks at the restrictions. The code, of course, says that restrictions should be minimal and should be avoided and all this sort of thing. So we were looking at this, and certainly some of our inspectors had gone into services that had smoke-free things and raised the very issue of smoke-free services themselves as a blanket restriction and questioning whether or not this was appropriate for reasons that, in a sense, we've heard so far. Obviously, there's some concern that if you detain a person in a service and they haven't had the opportunity to decide whether or not they want to engage with it, do we use captivity to enforce our lifestyle choices, as it was said earlier on? So you can see that in some sense it's a reflection of that. Now, we wanted to move away from having very sterile argument along those lines, and so we've really produced a policy position which accepts smoke-free services much like we accept the fact that alcohol is banned in mental health services. The analogy is not perfect. It's not, it can be argued against or for depending on your point of view. But basically, that's the position that we want people to take because, frankly, the argument is over. So if we move on to my third slide, I'm just going to run through the key things that our brief guide says, and I doubt that it's going to take all the time that I need, and then open it up for people's questions, really. Here we have, this is the opening lines of our brief guide, where, as you can see, in effect, we are setting out that smoke-free policies may well be contentious with certain staff, with certain patients, and all the rest of it, but the Court of Appeal has made its ruling. That ruling hasn't actually been changed by the Supreme Court, which has recently discussed the issue in relation to Scotland. And as we say, services are just mandated by commissioning authorities to implement the smoke-free policy. So this is the situation that we find, and we're certainly not wanting to be the organisation to challenge it. So, fourth slide, please. Here's our basic principle. We're not going to challenge the policy, particularly in relation to blanket restrictions, but what we do want to do is to see how it is being implemented. Because I think that certainly our experience was that some of the early implementation of smoke-free policies was all about what you can't do with very little support to help people with, for instance, smoking cessation. We're particularly keen on seeing the behavioral support and the nicotine replacement therapy, and I think particularly, and I was struck by the example of the Northeast, that actually it seems to me that both inside and outside hospital, one of the most effective tools that we have to help people not to smoke cigarettes are electronic cigarettes. And certainly there's been a lot of confusion in mental health services about whether or not electronic cigarettes can be used safely and all the rest of it. But in general terms, we're finding that more and more services are finding that that's their best route to enable patients to stop. So, fifth slide, please. It says reporting at the top, just to make sure that we're all still in sync. So we're saying here, we therefore not raising questions about blanket restrictions. However, you might find that if there is a blanket restriction on e-cigarettes with no cogent justification for them, that might get raised by CQ&C inspectors. Cogent justification really just means any rationale whatsoever that's reasonable, and there are services in certain levels of security and so forth that we may well have those kind of justifications. Nevertheless, the prison service has developed e-cigarettes that are safe to use in prisons. If they have, then it seems to me that it's quite likely that there's no level of security that can't at least think about these things. We are very keen to see that services who have implemented smoke-free policies give their training to staff, and that there is proper access to smoking cessation report. And I think we've heard already that that means on-site, it means very quickly, and all the rest of it. And that there are medication reviews and monitoring, because as we all probably know in mental health, things like clozapine dosage and so forth, your plasma levels in your blood can be highly affected by the fact that you either stop or suddenly restart smoking. Therefore, dosages of certain medications can go a bit haywire and need to be carefully watched if people are suddenly abstaining or not abstaining. Sixth slide. Here I'm going into just, this is a checklist at the end of our brief guide. I should say, the brief guide, I don't think I've put a link up, which is stupid of me, but if people Google CQC brief guide smoke-free, the first one that comes up is the whole of this guidance. It's on our internet site, so it's publicly available. Here's a few things from the back pages, which is effectively a bit of a checklist for staff, for our staff, when they're looking around. Now, I have to say, we don't do this in every visit. We have to choose, I think, what our priorities are in each visit. There may well be services, I think, for instance, the ones that's just been described, where we go in and we're not terribly interested in inspecting the arrangements for smoke-free services, because on the very surface of it, it all looks absolutely fine and there's no issue for us to go into. I guess that actually the issues are more likely to be raised where patients complain to us, where staff seem uncertain, or indeed where you do something like you walk onto a smoke-free site and walk through a huddle of people smoking in the car park and all that sort of thing, which of course all those things happen to us. So you can see here that here's a few things that we look at in terms of policy, and I've just picked a few. This is not all of them, but as you can see, they are about, are staff aware of the policy? Is there a policy? Do people provide people with verbal and written information about the smoke-free policy before their appointment, procedure, or hospital stay? Quite an important point. As we've heard, nationally, we are hearing levels of detention going up. One of the reasons that we hear from staff, but this is not proved, and certainly in the case example we've just had, it was disproved. But one of the things that we hear from staff is that some patients are less willing to come into hospital voluntarily because of smoke-free services. Certainly, one of the problems would be if somebody's not been told about a smoke-free service and ends up in a site and then realizes what they've walked into and tries to discharge themselves. Very ineffective way of mental health care for people. So we want people to be told about it. Slide 7, please. We've got a list here of some of the training things. So there's a requirement staff are trained to deliver advice. I was interested to hear just now that one of the ways to do this with really good practice is to enable lots of staff to issue smoking nicotine replacement therapy straight away, so there's no waste of time and lots of people sitting about feeling anxious about the whole thing. That sounds really very good. And so you can see that's more or less where we're going with the training one. 8th slide, supporting service users. So one of the things that we'd be asking is whether or not during the first face-to-face contact, staff ask about smoking status and help people out. Certainly, as I've mentioned before, are people told in advance? Do people get the right NRT? That's fine. Behavioural support, as I've already mentioned, and do staff encourage the use of NRT for anyone who does not want or isn't ready or unable to stop completely? So as we've heard already, smoke-free services aren't about imposing the fact that people have to give up smoking. It's supporting them to desist from smoking whilst they're in the service, with the idea that they might carry that through and take that idea home with them. Have I got to the end of my slides? No. Right. I've talked already, sorry, slide 9, please. I've talked already about the issue of medication and blood levels, so I'll leave that with people. And then 10, slide 10, please. Supporting staff, all very important. Are these services helping staff to stop smoking? As we've heard already, I feel a bit like I'm repeating what other people have done, but you know, it's pretty hard when staff come onto the ward smelling of smoke, having just had a sneaky cigarette in their car, when all the patients are told they can't. So do staff get access to NRT? Does the service provide behavioural support to staff alongside the same as it's providing to patients? Those are the sort of questions we'll ask. And finally, slide 11. There are a few technical questions about what's in the pharmacy. So they have the full range of NRT. Do they have an on-site stop smoking service? As has been said before, very important that we're not looking that people are referred to some outpatient clinic when they get home or something, or even across the site. And is there a range of NRT available for visitors and staff? That's the end of my slides. I really am just going to, this whole intervention really was just pointing at our guidance. It's freely available. It does become a sort of de facto checklist for services to have a look at to see what they're doing in terms of smoke-free, because it was created in collaboration with ASH and other bodies who advised us on what a good service for smoke-free would look like. So it's perhaps another tool that people might want to use. And on that, I'm going to go quiet again.
Brilliant. Thank you, Matt. I think it's really interesting to hear what the kind of CQC expectations are of services, for us to be reflecting on whether our services are meeting those standards. Right, we are now going to move into the Q&A discussion, and so all of our speakers will be unmuted. Is that how we're going to do it? Okay, yep. Okay, so just to start the discussion, a bit more housekeeping. We've had a few questions about whether slides will be circulated. We can do that, and there'll also be a link available to this webinar, so you can go back and listen to it all again should you want to. There'll be a written Q&A for anything that we don't get to from your questions, because we've got lots and lots of questions here, so we probably won't get through them all in the 20 minutes we've got. After the event, we'll be circulating an evaluation. We'd really appreciate it if you would complete that. And also, Matt there mentioned links to the CQC documents and other things. We'll make sure that we circulate the links to important documents like the NICE Guidance and the CQC guidance. So, before we go into questions, I thought I would just read a note that we've had here from Jonathan from Barnet and Enfield Mental Health Trust, who is talking about their experience. So he has said, we had no extra posts, no conferences, minimal resources, nothing from commissioners. We spent 10,000 on communications and signage, 20,000 on level 2 training for 200 staff, and 20,000 a year on NRT. And that's for a mental health trust with 140 beds and 3,000 staff. Happy to tell people how to do it on a shoestring. I think, Jonathan, we'd be all really interested to hear about that. So if you want to send us some more information, then we can circulate that as well. So my first question to our speakers is one that actually came in before the webinar, and it's about how we can get buy-in for this activity. So how we can go about getting senior level buy-in for going smoke-free, especially among senior medical professionals. Leslie, I wonder if we could start with you about what your experience is of getting senior buy-in.
Yeah. I mean, with TZESC and Weir Valley, before I came in post, they'd already identified Nick Land as medical director. But I must say, I don't think anybody actively put the hand up to do this post. I think, fortunately for us, Nick was in the right place at the right time, and it was asked of him, would he be prepared to do it? And he said yes, but he was absolutely phenomenal. So I would say it's trying to find somebody who won't be pushed into it, but that actively will embrace it. Because if you have somebody who doesn't turn up to meetings or doesn't want to be there, then you're never going to be able to achieve it. So
you really need that senior level champion.
I mean, Nick actually did a lot of work that I as a project manager wouldn't have been able to do. When we had problems, he would take them to executive boards or to the chief exec, whereas I might not have had that pathway there. Problems were dealt with very quickly by Nick within hours, whereas it might have taken me months to do the same piece of work. So we wouldn't have been ready to go live if we hadn't had Nick pushing forward the things that we actually put in front of him on the table.
So, Debbie, does that chime with your experience as well, needing that senior level champion? How has SLAM gone about identifying them?
Yeah, I'd agree with Leslie. And in addition to that, what we did was we reminded clinicians and senior managers of the massive health disparity in the local population. So we tried to make the case locally relevant. So we fed back to them the smoking prevalence of patients in the trust, which in severe mental health population at the time, it was around 60 to 70%. In our who were treated in our drug and alcohol services, it was nearly 90% of them were smoking, and that was compared to a local prevalence at the time of about 20%. And we also reminded them of the mortality gap in our local patients compared to our local population, and also kind of had conversations with them about the effect of smoking and stopping smoking on mental health, which a lot of staff have not engaged with in the past, and kind of conveniently ignored of how smoking gets in the way of mental health recovery.
Thanks, Debbie. John, do you have anything to add to that, or should we?
No, only that I work in a trust where it's proved very difficult to find that champion, and our progress has been very slow as a consequence. You need somebody who wants to do this and who is very well connected at very senior level. And that's perhaps one reason why commissioners have a role to play in this, because we've heard a lot of examples of people who've gone down this route successfully, but the organisations are a bit slower to take it on, might just need a little bit of a push.
Brilliant. Thank you, John. I won't put that one to you, Matt, unless you've got anything particular you want to add.
No, that's fine.
Great. So we've had lots of questions about electronic cigarettes, some of them quite specific and some of them more general. John, I wonder if I could start with you. What role you think electronic cigarettes have to play in mental health trusts going smoke-free? John, could you turn your volume up a bit as well?
Oh, I'm sorry.
That's fine.
Okay. Electronic cigarettes have a huge contribution to make. They were absent from the NICE guidance simply because they were still at a relatively early stage of uptake in the UK when that guidance was being developed. Things have obviously changed, and so I think we have to embrace these opportunities, and particularly in mental health settings, but across the board, because they just make abstinence from smoking so much more acceptable and achievable for the many smokers who use services, aside from the ones who actually want to quit, the ones who are just willing to comply with a smoke-free policy while they're on site. So I think they've got a huge contribution.
Debbie and Leslie, or maybe start with Debbie, what's the experience of e-cigarettes in SLAM? Is there anything you'd want to add to that?
I agree with John, particularly about his point that they're an acceptable alternative to other nicotine replacement products. So smokers who have a mental health problem, they've not really been attracted to the local stop smoking services that do some great work, and I think some of that is because we've not offered, we've not just offered a way out of tobacco dependence for this group of people, but we've not offered them an acceptable way out, and I think electronic cigarettes offer that alternative, acceptable way out. They've proven very popular in SLAM and in other mental health trusts that I work with, and people, they've got some different experience about how satisfied they are with them, and I think that's largely because of the type of products that previously we've allowed in the local trust, so just allowing disposable e-cigarettes. Earlier this year we revised our smoke-free policy to allow the use of tank models as well, which are likely to be better nicotine delivery systems than the disposable models. So hopefully we'll see the uptake of e-cigarettes grow as we've widened the access to the different types of e-cigarettes.
Thanks, Debbie. I mean, Leslie, I wonder if you could talk about some of the practical issues around e-cigarettes. How do you make them available? You do make them available, don't you, in Tees, Esconware?
Yeah, we do.
And how do you go about doing that?
We very quickly realised from our service users when we questioned them that they wanted e-cigarettes in the trust. So our executive board were asked and they said yes. We decided to give disposable e-cigarettes free of charge, although they're not as effective as the other delivery systems. When patients come into care and they aren't well, it seemed that a lot of them preferred those than NRT. So what we do is each ward can buy a stock from our Lloyd's pharmacy, a box of 20. They can then either offer NRT or a free disposable e-cigarette on admission, and the staff members, 2 of them, would sign one out and give one to a service user. They're allowed 3 free of charge, so each one lasts about a day. They're allowed 3 free of charge, and then after that they would have to buy their own e-cigarette, or they can go on to free NRT. So we don't give them forever, because some of our patients are with us longer term than others. Currently we get them from Lloyd's, but we are aware that sort of there's like EBA and there's other ones which we are considering other trusts, but because we had such little time to get them in place, we went with the ones that our Lloyd's pharmacy provider had in stock. And each ward takes that, whatever amount they give out, they actually take from the ward funds. So it will come off their actual funding for the ward. But they've been massively embraced. We did allow them and the rechargeable. And then we had a couple of PALS complaints from 2 patients who had actually bought a tank model e-cigarette, the reservoir models, to bring into hospital with them, which were then taken off them, and they put PALS complaints in. So we went back to the executive board and they fully approved that we would be allowed to allow patients to use any form of e-cig. The rechargeable models and the tank models have to have a risk assessment completed before they're issued, just to make sure that the patient's safe to actually use those models in our care. Our forensic services don't allow any e-cigarettes, and that's just what they've chosen within their care because of the risks of self-harm by swallowing them and things like that. So that's the decision that our forensic services have taken. But I'm aware that South London and Moseley, I believe that you do allow the e-cigarettes in forensic services, but in our care it hasn't. And 158 of our patients in forensics went smoke-free without the use of e-cigs and did very, very well. So, but we have embraced e-cigs, and we've had no instances of setting fires or explosions or harm to patients. We've had no datixes linked to that, so we're very fortunate in that account.
Thanks, Leslie. Matt, you did mention the role of electronic cigarettes in your presentation. Is there anything more you'd like to add about where the CQC sees them in this discussion?
Well, I think our position is based upon what people have said, that actually services find and patients, they tell us that if e-cigarettes are available in some form or other, it's a lot of the heat out of the whole issue of smoke-free, if I can use that rather unfortunate analogy, in that, you know, it becomes very difficult to start to complain that somebody's rights have been reduced and so forth by the fact that they're required to use an e-cigarette rather than a rolled up piece of paper full of tobacco. It sort of becomes rather trivial. I think that's why to us it's been a really powerful thing that we've seen services start to embrace them. Because certainly if we go back a few years, as was said, the e-cigarettes were very much a new thing and hadn't been taken up more generally. But a few years ago, they would generally be not allowed in hospital services, and we found that people were much more anxious about the smoke-free services at that time.
Great, thanks, Matt. We've got lots and lots of questions. I think if we move on to talk about how we might deal with breaches to our policy. So we've got lots of different questions from people about managing staff or service users who refuse to stop smoking, issues around, I think you mentioned, Leslie, smoking in bedrooms and other places on the grounds. What advice do you have? We'll start perhaps with you, Debbie, on how to manage sort of breaches to the policy that you put in place in a way that will best achieve the goal that we want to, which is about this cultural shift away from smoking and towards being smoke-free.
I think the way staff have managed it in SLAM is to try and get the treatment pathways right. So making sure that people have rapid access to nicotine replacement, and then a bit later on in their treatment pathway, the option to have varenicline or bupropion or e-cigarettes. And for the first year, we took a fairly hands-off approach to the management of breaches. So we made sure that so if people were found to be smoking in their wards, as long as there wasn't an immediate fire risk, then we'd kind of back off and then have a conversation with patients about their care plans. So were they getting sufficient nicotine replacement therapy? Were they being given behavioural support to manage their tobacco dependence? And we also tried to avoid conversations about telling patients what they can't do in hospital, but start the conversation off with what we can do for patients in terms of providing them with support. And it's only kind of a couple of years after the implementation of the policy that then we then started a bigger programme of work to move towards a tobacco-free service rather than just a smoke-free service. So now there's a rollout of supporting each ward not to store any tobacco and not to be handing tobacco over to patients to take off the hospital site to smoke several times a day. So the wards don't store tobacco. Tobacco is either handed back to somebody who accompanies the patient for the admission, or it's destroyed. And what we're finding is, just like before we went smoke-free, there was an awful lot of anxiety. There was an awful lot of anxiety before we moved towards tobacco-free services. But again, once staff have been implementing those policies, they say exactly the same things in terms of, well, it's a lot easier than we imagined.
Thanks, Debbie. Matt, I wonder, do you have advice from the CQC perspective about, where there are breaches in the policy, how that ought to be managed?
Well, I suppose really all I can do is reinforce what's already been said. What I think is the key is we would be concerned if we're seeing a punitive environment starting to be established because of this. But in that sense, mental health services are already all engaged in programs of reducing their restrictive interventions, and the way they're all doing that is with the kind of safe wards and talk down and all those kind of different ways in which it's about reversing the discussion from what you're not allowed to do to turn it around to what you could do and what solutions are. So I think that actually mental health services are becoming much better aware of that side of how to manage all sorts of behaviours, and we would expect that that wouldn't be any different for managing smoking behaviours.
Thanks, Matt. Leslie, I wonder if you could talk to that specific practical question, you know, what you did around patients smoking in their bedrooms.
Yeah, I mean, it's least restrictive practice to do it, and very much in our policy it states that staff should not put themselves at risk. So we do still have challenges whereby staff contact us to say that a patient has become very aggressive, and I think we've only been smoke-free for just over a year. And I very much believe that in 2020 we'll be a completely different trust. Within a year we've made massive steps to go completely smoke-free. But as Debbie's mentioned there, we initially, the policy was very clear that if anybody brought tobacco in with them, they would be asked to return it home, or it would be stored and locked away. That didn't work. Staff actively were facilitating smoking and giving cigarettes back every 20 minutes. So we then brought in October, Nick Land, Medical Director, wrote a letter to all wards and to all consultants to say that that practice had to cease, and that as of October 16, no patient who came in with tobacco would be allowed to have it returned until final discharge. Now, in some areas that's been followed to a T. That's working really well. Our patients are being told not to bring it in with them. In other areas, staff are still struggling with that. They still feel it's their tobacco and they should be allowed to be given it. I just think with breaches, we're getting better. We just have to keep moving forward. We are still going to have patients smoking in courtyards, in gardens, in bedrooms. We just have to manage it the best we can at this time, and then it will change. The actual practice will change over months and years as we move forward. So if we did another conversation in a year's time, I believe Debbie and I will be able to tell new stories, and we're moving forward even further. But it just takes that time to embed.
Oh, we'll hold you to that, Leslie. I'm just going to move on to a different issue now and come to you, John. We've got some questions about how we might, you know, it seems key from all of the presentations that we've had that the role of staff and staff being properly trained is really important. And we've got some questions about how that might be best achieved. So there was a question here about whether it would be beneficial that smoking cessation training be mandatory for mental health staff. I wonder if you've got any reflections on how we can make sure that that staff in mental health settings are fully and appropriately trained on this issue.
Mandatory training is a fairly contentious issue, and like all NHS employees, I undertake a lot of it, and not all of it is of the highest standard, I have to say. So I would welcome the inclusion of smoking cessation training in my mandatory training package. What other trusts have done is to use training based on the NCSCT online services. And that seems to be something that people can do in their own time or in spare bits of time during the working day fairly easily. But the more intensive training needed to support, to actually deliver behavioural support is obviously a much bigger undertaking. And that's not feasible for the mandatory training process. But simple interventions to when you see breaches of smoke-free policy, and the early things to say to smokers when they're first admitted to hospital or into outpatients or wherever, is something that could easily be done on the mandatory training system through one of the online systems.
Great, thanks, John. We're nearing the end of our time, but I wonder if there are any particular parts of the training that you've had in SLAM or in TZESC and WEIR that you think, you know, if you're going to do one thing around training, if that's all that you've got the kind of capacity and resources to do, what the most important thing is for trust to get in place as they're moving to be smoke-free. I'll ask you first, Leslie, and then you, Debbie.
We realised in the first year we trained over 1,500 staff in the level 1, which was great. But this year we've struggled more to get staff. NICE recommends that you actually update yearly on that training. So what we've done is developed a paper version of it for those who need to update. We cascaded that. That didn't get many responses. We've been to our executive board and now got the level 1 training as an essential training. So it's not mandatory, but it's essential and it's actually being put on the ESR system. And within days, 50 staff completed it. So we've managed to find a process whereby we can get staff to actually complete it. But we know that mandatory, there's so many sessions on mandatory that we've gone essential instead. It is very similar, but it means that actively we're getting dozens of staff now completing it. I do think the level 2 is very, very detailed and can be very difficult for staff who are struggling with staff levels on the wards and things like that. So the brief intervention, 2 hours, staff have massively embraced with us, and we've had literally hundreds of staff have attended that session because it's a shorter session without an exam at the end. And we find that's probably the best way forward for us, all staff to complete level 1 and as many staff as possible to attend our face-to-face level brief intervention training. So for us, that's working for us. It may be different for other trusts.
Thanks, Leslie. And does that chime with your experience, Debbie, in 30 seconds?
Yeah, it is. I suppose if there's one thing I think mental health staff should understand is the difference between tobacco and nicotine, and the importance of separating the nicotine from the tobacco smoke. And then once you have a good understanding of what nicotine is and isn't, and how it can, how replacing nicotine can help someone's tobacco dependence, but this whole smoke-free journey, then I think the implementation of smoke-free policies will be a bit smoother.
Brilliant. Thank you all to all the speakers today. I think it's been a really, really interesting session, and I note that most of our attendees have made it all the way to the end, so clearly there is a view out there that it's been a very interesting discussion today. I think what I've really taken away is how this is an ongoing process of change for mental health. That you know, this not the process of going smoke-free is an important process. It's not achieved overnight, but also that this is having an impact on mental health services, and over time, you know, we really will see changes. So perhaps, Leslie, we will come back again in a year's time and see what's happened. As I say, we will circulate the links to the webinar when it's up and available to see, and to the presentations. And many thanks for all your time today, everybody.
Thank you.
Thank you.
Thank you.
Thanks, Rob.